Okay, so we're a couple minutes in and we already have a good number of people here, and I know more will be joining. So I want to just greet everyone and kick us off. So good morning. Welcome to our one of our fall rounds, and happy fall to everyone. Hope everyone's doing well. I will mention our other remaining rounds for the month of October, and that is on October 20th. We have two of our current postdoctoral research fellows, and they are Red Driver, who will be talking about sexual orientation-related differences in HIV risk among Black SMM in the Deep South, the N2 cohort study. And Ohema Poku will be talking about the Safe Haven Intervention, implications of a near-peer youth lay counseling initiative, and opportunities for future research. And I'll just mention the dates for our November rounds, and they will be November 3rd and November 17th. So keep those in your calendar. I'll pause for just a moment to ask if anyone has any announcements that they'd like to make. And if you do, you can just indicate so, and Stephen can unmute you, or you want to put something in the chat. Okay, assuming there are no other announcements, I will introduce today's speaker, and then I'll be turning it over to our presenter. And also, as usual, Stephen will facilitate the Q&A and the discussion. Always a reminder, keep yourselves on mute during the presentation, and we'll have plenty of time for Q&A and discussion afterwards. So we have the pleasure to have today with us Dr. Florence Momplaisir, who is an assistant professor in the Division of Infectious Diseases. She's vice chief for diversity, equity, and inclusion in ID, and a senior fellow of the Penn Leonard Davis Institute of Health Economics at UPenn. Dr. Momplaisir serves as a co-director of their CFAR scientific working group that is focused on using implementation science methods to end the HIV epidemic regionally. Just briefly, her clinical research focuses on improving postpartum retention and viral suppression of cisgender women living with HIV, and on decreasing racial disparities in HIV prevalence among US populations. She's currently PI for 2 R01 funded studies, which are focused on using lay workers to implement theory-driven behavioral interventions to improve adherence to antiretroviral therapy and engagement in HIV care. Thank you so much for being with us today, Florence, and I am going to turn the floor over to you.
Thank you so much, Robert, and thank you, CEO and Stephen, for allowing me to come and speak to your group. I'm very excited and humbled to be here. So the title of my talk is Implementation Science to Address Gaps in the HIV Care Continuum for Adolescents Transitioning to Adult HIV Care. I have no conflicts of interest, but I do have a disclosure, and that is that I am submitting my file for promotion. I'm currently an assistant professor. And at the end of the talk, I included a QRS code that you can use for the evaluation of this talk, as those comments can be included in my dossier. So I appreciate for those of you who can take the time to do this at the end of the talk. So what we'll talk about in the next hour is to start with the epidemiology of HIV among youth and young adults. I think a lot of the data you're already familiar with, but I really want to focus on why this population is particularly important as we engage in ending the HIV epidemic efforts. And I'm going to focus particularly on the healthcare transition of youth and young adults as they transition from pediatric to adult HIV care, and think at multiple levels the barriers and facilitators associated with the healthcare transition. And in particular, I will focus on discussing the results of a recent pilot that I led, where I use mixed method to understand and engage in a contextual inquiry of the healthcare transition using the perspectives of patients, clinicians, and a policymaker of the Philadelphia Department of Public Health. And that's really because there hasn't been a lot of intervention focused on addressing the healthcare transition as youth transition from pediatric to adult care. And I really wanted to understand the lay of the land using multiple perspectives and really understand the set of implementation strategies that can be used to support this population. I will also describe the results of a population-based cohort where we describe viral suppression trajectory groups, and I'll go over what that means exactly. And throughout the talk, I will discuss the use of implementation strategies that emerged during this work to optimize the healthcare transition. First, I want to take a step back and just briefly speak of my journey. I think we all have personal reasons as to what we do and engage in the work that we do. For me, I was born and raised in Port-au-Prince, Haiti, which is a resource poor country, as many of you know. And my parents were the first generation to achieve higher education, and particularly my mother and grandmother served as a great role model to me. And I really saw them sort of navigate issues related to gender inequity. And that's why I think my work around HIV and women's health really sort of was inspired by their stories. But also because of the structural inequities that are very much present in Haitian society, I really felt the inspiration to really focus on social determinants of health to improve population health. And also want to say that in my clinical practice, I mostly focus on pregnant and postpartum women living with HIV, and in that setting, had the opportunity to take care of women's children and also take care of adolescents who are transitioning to adult care. And this again helped inform the research questions that I'm gonna pose today. Having said that, I think for a lot of physician scientists, our research questions really are embedded in clinical scenarios, and this was the case for this pilot as well. So these two patients were patients that I actually saw in 2019 as they transitioned to me from pediatric to adult care. The first one was a 25-year-old cisgender woman who acquired HIV at birth. And she transitioned to me really in the midst of the pandemic. And her transition was delayed by multiple hospitalizations because of urinary tract infections that were becoming more severe and more complicated by multi-drug resistance. In addition to that, she had moderate to severe depression and had lost her mom from HIV and AIDS, was raised by her father who was providing social support. But by the time she transitioned to me, she had an undetectable CD4, so she was very immunosuppressed and in HIV AIDS and had a very high viral load. The second patient who transitioned to me was a 25-year-old cisgender man who also acquired HIV at birth. And similarly to the prior patient, struggled a lot with adhering to his HIV medications during adolescence, to the point where he needed to have a PEG tube case in order to receive his medication. His HIV was complicated by HIV-induced nephropathy, which is the damage of HIV infection to the kidneys. But he was able to achieve viral suppression a few years prior to transitioning to me, and was actually suppressed by the time he came to the adult HIV clinic. Similarly, he had lost his mother from HIV and AIDS and was raised by his father and was receiving social support from his father. And when thinking of those two patients, as an adult provider, the questions that I had were, what are the individual level and also the clinic level factors that can influence the transition of youth who are coming to adult care, but also what are the factors that influence their success long-term in terms of retention and viral suppression after the healthcare transition. And also in the era where we're being more mindful around health equity issues and placing less of the burden in terms of change on the patient, but also thinking of us as the healthcare system, of things that we can do to maximize success for those youth after they transition to adult HIV care. So in particular, thinking of the strategies that we can implement or emphasize during this time of transition for youth. So as you probably already know, viral suppression is very low, and it's probably the lowest among youth and young adults living with HIV compared to older adults. This graph shows the HIV care continuum of youth living with HIV across 12 urban health centers in the US. And as you can see, there is a drop for each of the steps of the HIV care continuum, with viral suppression being the lowest at 12%. And this has been demonstrated over and over again across numerous studies. But the good news is that as individuals age with HIV, we know that viral suppression actually gets better over time. These sets of graphs reflect an analysis that was published in the Annals of Internal Medicine, where the investigators looked at viral suppression over time between the sort of early onset of the pandemic up until 2015. And as you can see, viral suppression increases with age in a dose-related fashion. So we know that youth living with HIV have poor viral suppression. Over time, with age, we know that viral suppression tends to improve, and that's a good thing. The question is really, how does the healthcare transition play in all of this? Do youth usually struggle, and viral suppression actually lowers because of this transition of care, or are they doing okay? And we don't have a lot of data actually to sort of answer that question. And because all EHE efforts are local, because they're based on the context in which people live, I wanted to sort of tell the Philadelphia story. This is a dashboard that the Philadelphia Department of Public Health actually has available to all. And it describes the volume of HIV viral load testing before the stay-at-home order of the pandemic, during the same at-home order, and afterwards. And as you can see, compared to before the pandemic, there was a short drop in HIV viral load testing orders. Particularly, the lowest drop was during the stay-at-home order, and it increased very nicely afterwards. However, it did not return to the pre-pandemic levels. And this is important because we know that youth living with HIV have the lowest level of viral suppression. It's unclear how they're doing, particularly during this time of COVID-19, but also for those who are transitioning to adult care, it's unclear how well they are able to maintain viral suppression. And in the dashboard, the health department also includes each of the steps in the EH plan, as you can see, with the goal of reducing new HIV infection by 75% in 5 years. And there are actual numbers that are being tracked every year to know how well we're doing. And so the goal here by 2025 is to decrease the number of new infections by 118. I'm gonna point your attention here to the last domain, which is to increase viral suppression to 95% by 2025. And as you can see here, we are actually going in the wrong direction in 2020. We don't have the 2021 data yet, but it just, this is important just because we know that youth in particular are very vulnerable, and it's unclear how their care is being affected during the pandemic. Furthermore, I'd like to provide some context around pediatric HIV care in Philadelphia. So there are 3 large pediatric HIV clinics where the majority of patients living with HIV are in care. What's really important about those clinics is to know that the population and the model of care differs. So in one of the clinics, the Dorothy Mount Center, care is very well integrated, such that youth who attend pediatric care, once they have to transition to adult care, remain in the same physical location. And they also have the same care team who follows them. So their caseworker, their social worker, their behavioral health consultant all remain the same. And there is an adult HIV provider who comes and sees those patients in the pediatric setting. On the other hand, the 2 other clinics have a different model of care where the youth have to physically transition out of the clinic and go to another health system. And the population also differs, such as at the Dorothy Mount Center, there's a mix of youth who acquired HIV during adolescence and youth who acquired HIV during birth, versus in AI, which is one of the clinics associated with the Children's Hospital of Philadelphia. The majority of them have youth who behaviorally acquired HIV, compared to the other perinatal HIV clinic where there's mostly just individuals who acquired HIV at birth. And the reason why this is important to mention is because youth who acquired HIV at birth have different needs and different set of barriers compared to youth who acquired HIV later on in their lives. Now, thinking about the healthcare transition, it's really, the reason why I have the definition here is really because it's not a sort of a dichotomous process. It's really sort of a planned and purposeful process that starts very early on in the lives of youth living with HIV. And it's defined as a purposeful planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented health system. And the goal is to really help them engage in care, both in the pediatric and the adult side, and have them receive developmentally and medically appropriate care in order for them to have a good quality of life. And in the process, hopefully the patient should be at the center of the intervention and the support. And obviously, youth with HIV have different level of developmental maturity, particularly when thinking of those who are perinatally infected, just because of the chronic exposure of HIV to the brain. This is even more relevant to them. And they should hopefully receive support from their care team members and also the individual serving as a parent for them. And there are modifiable subjective variables that hopefully the care team and the parent are helping this youth or young adult to acquire skills and also help their health beliefs to align with the expectations, particularly for care as a transition, in order to help them be prepared and ready for the healthcare transition. There are also other objective factors that are less amenable to intervention, like sociodemographic characteristics, access to medical health insurance, that are still important to think about and address when caring for them. And this graph really shows the process of the healthcare transition, again, to emphasize that unlike other settings, for example, where patients transition from the inpatient to the outpatient setting or transition from pregnancy to the postpartum period, the healthcare transition for youth is a planned process that starts years before the actual transition. And my pediatric colleagues tell me that they really start engaging in conversation around transitioning, at least at the age of 12 to 14. They come up with a specific plan with the care team and the individual serving as a support system for the youth, and help the youth assess and acquire skills in order to be ready for the healthcare transition. And after the transition, there should be hopefully a feedback loop to make sure that they actually got linked to care and that they are engaged in HIV care. In adult HIV, the age of transition really varies between age 18 to 25 in Philadelphia, just because of the strict requirement that youth need to transition to adult care by the age of 26. So pediatricians are no longer able to keep them in their practice past that age cutoff. And in preparation for this talk, I did a brief literature review just to really look at the data and to see how youth are doing pre and post healthcare transition. And this slide sort of summarizes key publications regarding this. I tried to remain within resource-rich countries, and the take-home point here is that the data is really mixed. As you can see, for some studies, viral suppression goes down, patient CD4 count goes down, meaning that they become more immunocompromised post-healthcare transition. In some studies, viral suppression goes up, and in this large cohort from the UK, youth living with HIV experience high levels of mortality post-transition. What's also important to see is that the population of youth also differs from those who were perinatally infected to those who were behaviorally infected. And along that line, the number of patients included also differs from a small sample to a large sample. For the study with the largest sample, they really focused on youth with perinatal HIV. So what's really lacking here is data from a large population-based cohort to understand really at the big picture level how youth are doing regardless of the mode of HIV acquisition. So our aims were to understand the implementation context for healthcare transition using patient and clinician perspectives, and also big data, particularly HIV surveillance data from the Philadelphia Department of Public Health. And what we really wanted to do is to understand the barriers and facilitators to healthcare transition and identify bridging and innovation factors that can optimize the healthcare transition. And I will explain a little bit more what I mean by bridging and innovation factors. And this work would hopefully inform the selection of implementation strategies that could be adopted in the healthcare transition setting. So I'm gonna start by providing or discussing the results of our qualitative interviews. So for this, we use the EPIS framework, which is an implementation science framework that thinks of different phases when one has an evidence-based practice in mind that they wanna implement. So it starts with the exploration phase, just to make sure that the stakeholders that will be using this evidence-based practice think that this EBP is acceptable and would be feasible in their setting. the preparation phase, the implementation phase, and the sustainment phase. And with each of those stages, there are implementation strategies that can be used in order to make sure that the implementation, the EBP is sustained. For us, based on our literature review, there hasn't been a lot focused for youth living with HIV in terms of EBPs. When we started this work, there were none. Currently, there is one intervention that's being tested in a clinical trial. So we felt that it was most appropriate to really focus on the exploration phase and understand the emergent or existing patient health needs and work to identify the best set of strategies that would help address those needs and really understand sort of the lay of the land in terms of implementation strategies for this population. So for the patient interviews, the inclusion criteria were that individuals needed to have an established diagnosis of HIV and be in care in one of the 3 pediatric HIV clinics that I mentioned before. And we wanted to make sure that they had well-established pediatric care before the healthcare transition and that they needed to be in care at least 2 years before transitioning, and that they were in care in the adult setting up to 18 months post-healthcare transition, because we wanted to give them the chance to actually get linked to adult HIV care. And they had to be age 18 or older at the time of the interview. Our instrument really focused on assessing barriers and facilitators to a successful healthcare transition, and really assess whether the youth felt prepared for the transition process, what helped them to be prepared, what inhibited this process, and understanding key individuals that served as a support for them for the healthcare transition. And we also asked them about their perspective on strategies to improve the healthcare transition. Now, for the clinician interviews, we focus on clinical care team members across the 3 pediatric clinics that I mentioned, and we also included 3 large adult clinics in Philadelphia. The care team that were involved in the interviews were multidisciplinary in nature, just to reflect the structure of the teams on the ground. So they included physicians, nurses, case managers, social workers, a behavioral health consultant, and youth counselors, and also clinic administrators. We included the perspective of a policymaker from the Philadelphia Department of Public Health. I realize that we are not achieving saturation here. We just wanted to have at least a perspective from a policymaker. And for the clinician interviews, the instrument really focused on the specific role of the clinician that the clinician played in the healthcare transition process, and focusing mostly on the inner setting and the clinic resources and clinic processes that may impede or support the healthcare transition, and also asking the clinicians on their perspective as to to name an individual who could provide social support or facilitate the healthcare transition process for youth. In terms of the data analysis, we use the modified grounded theory for the data analysis. The inductive content, really, we use the constant comparative method for this. And we use the EPIS framework for the deductive content of the analysis. And patients and clinicians were, in addition to that, asked to name and rank barriers and facilitators associated with the healthcare transition from most to least significant. So we so far interviewed 19 patients. We have one more interview to go, and the average age was 26. Half of them were cisgender women, 93% were Black non-Hispanic, and 67% reported that they were virally suppressed before the healthcare transition. We interviewed 20 clinicians. The demographic profile is listed here. The majority of them were white, non-Hispanic, cisgender women, and 45% of them had about 11 to 20 years of experience in the field of HIV. So for this slide, I'm really presenting the results using patients' perspective on the barriers of healthcare transition. And they are ranked from most significant to least significant. I also use a color coding scheme to reflect in yellow the interpersonal barriers, and in blue the structural barriers, and in pink the individual level barriers. So as you can see, the three most significant barriers were really interpersonal in nature. And the first one was difficulty trusting the new clinician. So youth had formed very strong bonds with the pediatric HIV team. There was a lot of anxiety around transitioning to a new care team. Particularly, there were concerns about feeling judged for their medical history and reluctance to share sensitive or traumatic parts of their lives. Leaving the pediatric team was also very difficult for them, particularly for those with perinatal HIV, where for their entire lives, they were cared by those team members. Communication issues. Youth felt that adult providers had heavier caseloads and also saw patients less often. So in the pediatric world, usually youth are seen every month. And in the adult world, they're seen every 3 to 6 months. So they were frustrations in general with slow response time to their concerns and also issues with decentralized communication. And those things really hindered their attempts to build trust. Appointment scheduling was the fourth impactful barrier. Youth felt that they were really frustrated with the wait time to see their doctor. It was really difficult to schedule their appointments. Usually on the pediatric side, the social workers were very hands-on in terms of scheduling appointments. And in the adult side, they were left with having the autonomy to do this themselves. And in addition to the communication issues, that really brought a lot of frustration for them. Some also felt that the appointment times were less flexible and did not fit with their work schedule. The fifth most important barrier was adjustment to the adult healthcare system. In general, youth felt that there was a different culture and climate in the adult clinics. Some of that were structural barriers because of the fewer appointments, for example, that were scheduled, but there were also logistical issues when thinking of going to a new clinic, and also having more responsibility in order to really continue engaging in care and a general change in routine. For some patients, transportation was an issue because there were longer distances to reach the adult care team's office. Now, for the clinician's perspective, the two most impactful barriers were also interpersonal in nature. Clinicians also acknowledged, similarly to patients, that leaving the pediatric team was the most significant barrier from their perspective, followed by communication issues, and difficulty trusting the new physician came further down in the fifth position. Clinicians, as opposed to patients, also brought up individual level barriers. They felt that patients, particularly because they transition with different levels of maturity and different levels of skill, some of them had poor self-efficacy when it came to adherence and retention in care, and didn't feel that they were really prepared for the transition to the adult HIV. Fourth, increased autonomy, again, because there is a strict age cutoff by which youth have to transition, whether they feel ready or not. And they felt that this was another barrier for them. And the development stage came on the sixth position. And this is really, I'm putting them together to really sort of compare and contrast the fact that some of the barriers, particularly brought up by patients, were structural in nature and were not brought up by clinicians. And clinicians really tended to focus, in addition to the interpersonal factors, really what the patient needed to improve their skill building and their self-efficacy for the healthcare transition. And none of the structural level barriers were brought up by clinicians. Now, in terms of facilitators, starting with the patient perspective, patient, although felt that it was difficult to create trust with a new care team, they really valued this when it happened. So patients valued the providers who made effort in building a relationship with them and trusted their judgment when it came to care. In second position, the most impactful facilitator was having support from a social worker and case manager. And there were a lot of quotes around their case manager providing emotional support, but also logistical support to help them navigate the transition process and the appointments and refills, et cetera. And there were stories of strong relationship between the social worker and the case manager. The rest of the facilitators are really sort of structural in nature, and they include providing a warm handoff. And this actually took place in different ways based on the clinic. For some clinics, obviously when care is integrated, it's easier because the adult provider actually came to visit the youth even before the healthcare transition by coming in the exam room and introducing himself or herself. In sites where care wasn't integrated, this took place less consistently, but there were efforts, for example, to have the adult clinician come to the pediatric clinic to meet the youth, or doing a video call, or the team themselves telling them specifically about the adult provider that they would be transitioning to. But in general, youth felt that this was a very helpful process and it leveraged the existing trust between the patient and the pediatric care team. Referral from the pediatric provider, even in the absence of a warm handoff, patients valued the guidance of the pediatric team as to where to go for adult care. And patients really wanted to maintain a relationship with the pediatric team even after the healthcare transition, just because they had formed trusted relationship with them. They knew how to get their questions answered, and they really wanted to, they saw this as a facilitator for the healthcare transition to keep those relationships fluid. And co-located care came as a facilitator as well, just because youth were in routine and familiar surroundings, and the transition wasn't as abrupt for them. Now, on the clinician's perspective, having support from a social worker and case manager came as the first facilitator. And then the clinicians really focused on the transition preparation process, having co-located care and providing a warm handoff, and also included individual level facilitators, such as youth being adjusted to their HIV diagnosis and having increased health literacy, which they felt were very helpful for continued care engagement and adherence. Now, when thinking of the inner context, which is really the clinic setting, as compared to the outer context, which are related to social determinants that occur in the community, there were very strong themes comparing and contrasting the culture and climate in the pediatric HIV clinics compared to the adult HIV clinics. In general, both providers and patients expressed the fact that pediatric clinics in general are well resourced there are large patient to provider ratio that allow for the development of close and long-lasting relationships. And there is strong comprehensive care with primary and behavioral health also already embedded in pediatric care. And patients particularly appreciated the fact that staff provided routine check-in to help them with social support and also addressing social determinants of health. On the adult care side, the teams are also multidisciplinary in nature. However, the intensity by which those resources are available to youth were not as consistent. One of the issues that actually comes up pretty routinely in adult care relates to health insurance, because on the adult care side, we can no longer accept patients under their parents' health insurance. They need to have their own. And this sometimes can create a barrier for during the transition process. We talked about the fewer appointments, and they were also quotes related to the built environment, the waiting room not being as friendly, youth-friendly, for example, to them. So I'm trying to really sort of summarize the themes that came up using the EP's framework, and really sort of dividing things on the inner context, which is really the factors related to the clinic and how clinic resources can facilitate or actually impede the healthcare transition process. We talked about most of those themes, and they're summarized here. The outer context, really think of it as sort of the community level barriers and facilitators that can impede the healthcare transition process. And they include food and housing insecurity, issues related to transportation, and HIV stigma and lack of social support. Bridging factors or factors that are already present both in the pediatric and adult context, but they're not used consistently across the clinics as an implementation strategy. So for example, medical record transfer, providing a warm handoff, having the pediatric teams really come up with a network of youth-friendly adult clinics, and varying case management models. So for example, in Philadelphia, we are currently testing a new case management model for youth who are transitioning, where the pediatric case manager can stay with the youth who is transitioning for up to a year after the healthcare transition. In some adult clinics, there is a dedicated youth case manager who spends more time with youth up to the age of 29 and can really focus on youth who are transitioning to adult care. However, those resources are not really consistent across care settings. And innovation factors are really factors that came up as new strategies in the interviews that were not already embedded in the clinics. Patients in particular felt that they needed longer new patient visits just to understand the new context of the adult care clinics, understand what their roles and responsibilities and how they differed from the pediatric context. And they really felt that having 1 hour wasn't enough for them to understand and gather all of that information. Sharing provider profiles with patients, and that came up as really as the use of an app, for example, where the provider profiles would be present and youth could really get to know and learn more about their new adult care providers. Increased health communication, particularly patients felt that they wanted to be able to directly text their providers without having to go through multiple layers of bureaucracy to reach them. And spacing of pediatric visits actually came from the policymaker from the health department, because they felt that the intense hand-holding from the pediatric care side sometimes could serve as a barrier to successful care engagement later on, just because the expectations were very different in both sides. So particularly for youth who were doing well, who were virally suppressed and engaged in care, they suggested that spacing the pediatric visits for them at least a year before transition would be helpful, because it wouldn't be such an abrupt change in routine when the youth reach adult care. And when asking about individuals who could serve as a support system for patients, patients by far reported that their case manager and social worker were the best suited for that role. And we found that clinicians also by far identified a case manager and social worker for this. We also ask about other individuals, such as, for example, a peer facilitator. This came up for some clinicians, but not so much for patients. So in summary, pediatric and adult clinics have differing culture and practices that may serve as barriers or facilitators to healthcare transition. We found that interpersonal factors serve as the strongest barriers or facilitators. So both youth and clinicians acknowledge that forming a trusting relationship was very important, and when it was present, that it could serve as a facilitator, but when it was absent, that it would be a strong barrier as well. We also found, based on the differing levels of barriers of facilitators that occur between the patients and clinicians, that it's important to incorporate both perspectives when determining the set of implementation strategies, just because there needs to be buy-in from all sides when thinking of EBPs and implementation strategies to supporting this population. We also found that case managers and social workers were valued and were essential to the healthcare transition process. Also that it's important to reinforce best practices. For example, sharing of medical records should be done consistently. It's not always done consistently. And it's important to test innovative strategies, for example, mHealth communication directly between patients and their clinical care teams. Now I'm going to move to the use of big data to inform the healthcare transition. So traditionally, we use the HIV care continuum when thinking of the steps leading to viral suppression. It's a well-established measure that is being used across the board as a valid metric for the treatment success. The strength are that it's a standardized metric. It's used by clinics to report, for example, to local health departments, particularly for wide funded clinics. We have very strict metrics used from the HIV care continuum. And those are well integrated into the EHE goals. So at least we are able to compare, apples to apples instead of apples to oranges. And the limitation is that it's cross-sectional in nature. So as you can imagine, there are a lot of limitations for this based on when the data is captured. And it doesn't account for population dynamics. And the numbers can really change based on what is used for the numerator and the denominator. On the other end, viral suppression trajectory, basically what it does is that you measure the rate of viral suppression over time, and it provides a longitudinal continuum. The strengths are that it provides trends over time. It's a robust measure for health system performance, but the limitation is that it requires the use of large data sets to identify distinct trajectories, and you need to have technical expertise to actually engage in the work. And it's not widely used across health systems and across studies. So viral suppression trajectory groups have been used both quantitatively and qualitatively. This study published by Sophia Hussein from Emory really describes the different patterns of care engagement and viral suppression for youth who are transitioning from pediatric to adult care. So as you can see, there's sort of the ideal transition where the youth engages highly before the transition and after the transition process. There's also the abrupt transition where there is a lot of variation with care engagement and viral suppression. And in some cases, the youth is lost to care during pediatric care, but then emerges in care in the adult side. And those results were really based on qualitative interviews where she interviewed patients and providers to understand the different patterns of care engagement. This analysis was done by Dr. Kasaye, where she looked at the probability of viremia for cisgender women using a large cohort and looked at the viremia trends over time and really saw that there were 3 different trajectory groups that she's describing here with based on viral suppression trends. So again, this is also not a perfect measure, but it really provides sort of a big picture data and a robust trend of viral suppression compared to the HIV care continuum. So what we wanted to do is to use a cohort of HIV lab data from the health department because all the labs are reported to the health department and incorporated into EHARS, which is the Enhanced HIV/AIDS Reporting System. And we included those who we particularly wanted to focus on youth who transition from pediatric to adult HIV care, considering the 3 pediatric clinics that I mentioned before. And because it's a population-based data, we were able to capture all adults who transition to care regardless of the site of care. We included youth who received pediatric care between 2012 and 2019, who were age 18 or older at the time of care transition and had a HIV diagnosis at least 2 years prior to the healthcare transition date. And we did not report those who had died or lived outside of Philadelphia. We were able to include youth who transitioned to care, even if they were in Philadelphia jail or prison. And for this analysis, we really separated the time in buckets, in 6-month buckets, and really starting with 2 years before the healthcare transition, looked at HIV labs during those time frames to see whether they were suppressed or not. And we repeated the same analysis post-transition at 1 and 2 years. And the 2-year analysis was a secondary analysis. And viral suppression was defined as having a viral load less than 200 copies per ml in each of those 6 months interval. And if an individual had more than 1 viral load collected with each of the 6 months interval, all of them had to be suppressed to be considered virally suppressed. If there were no viral load given at the 6-month interval, then viral suppression status was considered missing for that interval. So we use a logistic trajectory analysis to identify the groups or clusters with different patterns in viral suppression over time. And we ran multiple trajectory models, varying the number of shapes of the trajectories and identified the best fit for our data. We also use chi-square and Fisher exact tests to assess the difference in the distribution of demographic and socioeconomic characteristics between those different groups. And use a GEE model to measure the association between the different trajectory groups and HIV care continuum measured up to 2 years post-healthcare transition. And because we wanted to be intentional around how to best consider missing viral load, we considered different scenarios that we incorporated in a secondary data analysis, just to see if we excluded those missing labs based on those different scenarios, whether it changed the results of our data analysis. So the results, overall, there were 232 youth who fit our inclusion criteria in this cohort of both youth who were perinatally infected and acquired HIV later in their lives. As you can see, 69% of them were between 24 to 25. The majority of them were Black males, which is a reflection of the HIV epidemic in Philadelphia. 29% had perinatal HIV. 10% of them had unstable housing. The majority used public health insurance and were at or below the federal poverty level. Now, starting with really sort of the HIV care continuum pre and post healthcare transition, what we found was that there was a small drop in receipt of care post healthcare transition, which wasn't statistically significant. However, retention in HIV care dropped pretty significantly post healthcare transition. However, this did not translate into a drop in viral suppression. Actually, viral suppression was slightly high, although this was not slightly higher, but although this was not statistically significant. And we also found that a greater proportion, about 78% of those aged 24 to 25, and those, the majority of those were perinatally infected, had a timely receipt of care. So these were the two factors associated with timely receipt of care. And also we found that a higher proportion of those who were perinatally infected were also retained in care in the year post-healthcare transition. And there were no other significant differences observed in terms of looking at the association between socio-demographic and the care continuum outcomes. Now, for the results of the viral suppression trajectory groups, we actually identified 3 distinct trajectory groups. One was high viral suppression, where youth had high viral suppression pre and post healthcare transition, increasing where the viral suppression increased pre healthcare transition and continued to do so after healthcare transition, and low, where youth had low viral suppression to begin with before and after healthcare transition. What we were really encouraged by is that there were no downward trends, meaning the case scenario where viral suppression was high during pediatric care and then dropped after healthcare transition did not form. And so that was just very encouraging to us. And the only variable that was associated with being in a high viral suppression trajectory group was being aged less than 24. And we really think that it's because pediatricians tend to hold on to youth who they felt are not ready for transition, and those who transition later at age 25, or probably those who struggle the most. But if they feel that they're ready earlier in life, then they transition them earlier to adult care. When looking at the association between viral suppression trajectory groups and the HIV care continuum outcomes, what we found was that particularly those who received, those who were retained in HIV care, particularly pre-healthcare transition, were more likely to have, to belong to the high viral suppression trajectory groups. And we also felt that viral suppression We also found that bowel suppression, pre-healthcare transition, also predicted what happened after healthcare transition. And those findings were for bowel suppression significant in the unadjusted and the adjusted analysis. When we performed the sensitivity analysis considering the missing viral load data, we found that the refitted trajectory models had a better fit as demonstrated by higher posterior probabilities. So in conclusion, we identified 3 longitudinal bowel suppression trajectory groups for youth with HIV transitioning from pediatric to adult care. They were the low, increasing, and high bowel suppression trajectory groups. We did not identify a decreased bowel suppression trajectory groups, which was encouraging. But overall, the rates of bowel suppression, even before and after healthcare transitions, are still low at 55 and 61%, which is lower than the overall bowel suppression rate for the population of people living with HIV in Philadelphia. We also found that retention dropped post-healthcare transition, although this did not translate in a significant drop in bowel suppression, which also was encouraging. And age less than 24 was the only factor associated with belonging to a high bowel suppression trajectory group. Youth with high probability of bowel suppression had greater odds of being retained in care and bowelly suppressed 2 years post-healthcare transition compared to those who belonged to the low bowel suppression trajectory groups. So it's not surprising that bowel suppression before predicts bowel suppression after healthcare transition. However, it's really helpful when thinking of the clinical context, how we can think about patients, particularly when they're not achieving bowel suppression pre-healthcare transition. So the limitation is that this was a relatively small sample size. There were potential unmeasured confoundings that we could not account for in the data analysis. And the missing viral loads were probably not missing at random. However, with the sensitivity analysis that we performed, this does not change the shape or number of trajectories. And time varying factors such as housing, insurance, or poverty level were captured at the end of the healthcare transition year. And this may have resulted in misclassification of these factors during the second year post-healthcare transition. So in summary, we found both using the qualitative interviews and the quantitative analysis that there are multiple factors influencing the healthcare transition for youth living with HIV. Particularly age came up and autonomy came up during the qualitative interviews, but in our data analysis, we found that youth who were younger and transition younger actually did better. The patient-provider relationship was one of the most impactful factors that serve as a facilitator for youth. Medical insurance came up during the qualitative interviews, particularly for youth who still remained under their parents' insurance. It came as a barrier. And what we really demonstrated is that we can use surveillance data or even clinic data in novel ways to really think of ways that we can better understand the trends of bowel suppression for youth living with HIV, but with also other populations and how this can inform strategies on the ground. We also found that case management came as a strong facilitator to the healthcare transition, in addition to providing a warm handoff in health communication. So how do our results sort of fit in the overall literature? Well, there was a prospective study of 14 clinics from the Adolescents Trial Network that evaluated the use of a checklist to support the healthcare transition for youth living with HIV. And the items that were included in this checklist emerge as a facilitator in our interviews, and they are listed here. And again, these are all of the themes that came up during the qualitative interviews. And in this study, the clinics who applied this checklist with consistency were 5 times more likely to have over 50% of their youth with HIV successfully transition to adult care. And so I think a lot of those tools are already present in the clinics, but not applied with consistency. And so what this shows is that we can be intentional around when thinking of strategies to supporting youth and think of ways to apply them with consistency to improve their health outcomes. So now I'm gonna end with the 2 cases that I presented earlier in the presentation, the 25-year-old female who were perinatally affected with HIV and transitioned to me with HIV and AIDS, and the 25-year-old male also who had perinatal HIV, who struggled with ART adherence during his adolescence, but was able to achieve viral suppression before healthcare transition. So the 25-year-old male really belonged to sort of the high viral suppression trajectory group and is continuing to do well post-healthcare transition. And my 25-year-old female patient really belonged to the low viral suppression trajectory group, and unfortunately is still struggling in the post-healthcare transition. So again, I think this tool can really help us when planning and identifying and risk stratifying patients before they transition and thinking of interventions that we can apply hopefully very early on in the pediatric world that can continue in the adult world to really support youth. So I'm gonna end by acknowledging my study team, community collaborators, the funders, and of course, our patients who participated in the interview. And this is the QRS code that I will also send to Stephen to hopefully share with you all to be able to provide your comments. So if you don't mind, I'm gonna stop sharing and take any questions that you may have.
Thank you, Florence. That was really great and it's really important work. So thank you again for sharing. So we'll jump into the Q&A portion. As a reminder to our attendees, if you have a question, you can either enter it in the chat or the Q&A feature or use the raise hand feature, and I will unmute you. Teo, go ahead.
That was indeed, Stephen, as you said, incredible piece of work. Fascinating to see how you can have an impact and doing that in such a grounded way. Florence, I would suggest that you leave up the sign so people can do that. And you explained before the session what this is about. Can you explain our attendees why you want to collect this information that might be helpful for them to know and motivate them to actually answer your questions?
Thank you so much, Theo, for bringing this up. Yes, so I am submitting my dossier for promotion. I'm currently an assistant professor, and I would appreciate if you can fill this evaluation using the QRS code that you can use for your phone. That will bring you to a link where you can include your comments that will be included in my dossier for promotion.
Thanks, Teo, for reminding us of that. We have a question or comment from Claude Mellons. Claude, you should be able to. Claude, go ahead.
Can you hear me now? Sorry.
Yes.
Yes?
Yep.
Yes.
Apologies, that got confusing. Thank you so much for such a really interesting and body of work that is near and dear to my heart. And I know a number of people on this call, and Stephen, who probably is too modest to say anything, was one of those fabulous case managers in a CBO trying to act, and actually at our medical center trying to hook those kids up. So Stephen, I'm just giving you a shout out because it's related to the results that were just here. So I do have a comment and question. It's more a question, but you presented data early on the mental health issues, and at least in our experience, that's a major barrier in this country for transition and viral suppression and staying in care. And so just a comment on that. And then my other comment has to do with, I guess, a systemic issue, which is part of the reason in the US that pediatric HIV clinics were so well funded, had that kind of support system, was they were created around a number of research projects. So not just the ATN, that was more adolescents, but there was a women infants transmission study, and there was a pediatric clinical trials group. And so the clinics got formed in some ways to house these research projects where many of these young people ended up. Those don't exist anymore, right? That funding is gone because we have no pediatric HIV epidemic here. But I think that, so I'm curious about how you think this translates moving forward, but more importantly, how you think it really translates to other countries and contexts where they don't have those resources, and what that transition may be like. So it's a couple of things that I think might be related to what we find, that the mental health is the most important, but I think the way pediatric HIV clinics were, and by default, they had to do so much of what you said. They had to join with the adult clinics to survive.
Absolutely. Thank you so much, Claude, for bringing those very important points. Unfortunately, depressive symptoms could not be captured as a variable in our analysis. I'm sure if we had that as a variable, that it would be strongly associated with outcomes. Part of what my first patient struggled with was really the trauma, honestly, from losing her mom and having to go to foster care for a number of years before returning to care with her dad. And there were a lot of superimposed mental health issues that were really difficult for us to address on the adult end when she was getting to know us, right? And having to encourage her to accept, for example, help from our behavioral health consultant. As you can imagine, those relationships are difficult to form and they take time. And so thank you so much for bringing that up. I think having been in both sides, where actually I was at the Dorothy Mount Center before coming to Penn, where I was one of those providers who came to the pediatric clinic to see patients. It's such a world of a difference when you think of the intensity and the care engagement provided from the pediatric team. They are very hands-on. They know everything related to the patient, related to the family. They know, all the events or changes that are occurring for the youth. Versus on the adult side, we tend to be more, we tend to engage more in a shared decision-making process where, we obviously try to empower our patients, but, tell them, okay, it's your choice. You do what, you do what you want, and we're here for you if you want it. It's a totally different approach. And to speak of, the resources, one example of how it translated recently for one of my patients is that because he works, he makes enough money, and so that was a problem with him receiving coverage for his copays. And the pediatric end, they sort of waived the copay, which was significant. It's like $40. On the adult world, we don't have that resource. And so it's a, there are a lot of differences that really translate on the ground with patients having a hard time on the adult world. So I'm not sure what the answer is, but I think it takes, all of us coming together and thinking about those issues.
Yeah, and all of those social determinants of health and health disparities that make the transition to young adulthood so hard when they're not in place, along with those mental health challenges. I'm smiling, and then I'll be quiet, Stephen. I'm smiling. I'm the mother of a 21 to 28-year-old. And, the hardest part for me personally is actually changing from, micromanaging everything to that transition. And so it is absolutely a struggle for pediatric providers to do that. Whereas adult providers haven't had that long history of a relationship. So that's also a really important point. I think they get frustrated also with young people. At least that's what we've heard in our work. So I think you raised a lot of food for thought about young adults in particular and what they need.
Thank you so much.
Thanks, Claude. Any other questions? We have some comments from Susan Tross, Florence. She says, this is such amazing work from clinical and methodological vantage points and a terrific use of mixed methods. Thank you so much. Theo?
Hi, Florence. I had one question about your implementation science work. So you gathered a lot of information. And one of the things that you found was that peer educators were not really seen as people who could help with the transition. The clinical providers had some different thoughts. They were a little bit more positive about peer educators. But as somebody who believes in the importance of people's social network, I was wondering, well, what does that actually mean that people say that they don't think that peer educators could be helpful? What is their information based upon? And could it be that a good intervention actually might show that peer educators could be incredibly helpful?
Thanks so much for this question, Theo. This was actually surprising to us. We had anticipated that youth would actually identify peers as a strong facilitator. I think there are multiple things coming to play here. One is that peers are not routinely embedded in clinical care on the pediatric side or the adult side as well. And so they know the case managers, they know their social workers, they know what they do, they understand their roles, versus perhaps the idea of a peer is more of an abstract concept for them. And so I think part of it is also not understanding what the role of the peer would be for them. Because I think ideally that's what you would want, is to have a youth who hopefully was in the high viral suppression trajectory group, or one that actually increased, who could coach and prepare the youth who is transitioning and saying, okay, this is what I went through, this is how I did it, it's not so scary, and sort of helping them navigate through the transition. To me, I think it's very compelling. I think part of it is, one, lack of understanding of their peer role. And two, I think also what we found is that patients tended to prefer low touch strategies. For example, texting. They didn't necessarily want to be called or have long conversations. They just wanted to text. They wanted to get a quick response. And I think part of it is also sort of the new way of communicating now. And so perhaps they felt that those sort of more tech related strategies to them were more acceptable. And I think that one of the reasons why peers came up as a facilitator for clinicians is because we understand the value of peers and really try to sort of advocate, although I think there's still more room to integrate them fully in HIV care. But I think it's an important strategy.
Thanks for that elaborate answer. Thank you.
Thanks, Theo. I believe we have a question from Phil.
I can't hear Bill.
Give me 1 second. Phil, you can go ahead.
Thanks. Hi, everyone. Thanks, Stephen. Yeah, wonderful presentation. And I really appreciate the comments that have been made so far. I had one, I noticed on one, you raised mHealth as like an innovative tool that we could use to address some of the, transitional questions. And I wondered if you could just say a little bit more about like specifically how, like what you think might work, or you might have seen through your experiences and the interviews you've done.
Yes, and actually we are in the process of piloting. Philadelphia is serving as a site for an intervention led by actually Sophia Hussein, who's at Emory, where she actually has created an app where patients are able to identify their adult provider and really ask questions ahead of time and text them, but through the app, through the secure app. I think it's a great idea. The issue I think that we're finding is that it's a separate system outside of the EHR where clinicians have to log in and engage with patients, which in practice comes at a disadvantage because clinicians have very little time in general. But I think that providing a way where, some providers, for example, feel comfortable sharing their work cell phone and having their patients text them, it's not, the case across the board. But I think that's what there's an appetite for on the patient side, is that they just want to be able to text and not call multiple numbers and get transferred to multiple people before they get their questions answered. So in practice, I think there are multiple ways to actually implement this. But more work needs to be done to sort of figure that out.
Thank you. Yeah, I appreciate that response, and it I think aligns with some of the things we heard in our work with the EHE supplement with young adults. So maybe future conversations. Thanks.
Thanks.
Thanks, Phil. We may have time for one other question. All right, looks like that's it. Thank you to everyone for participating, and thank you again, Florence. Bob, I will turn it back to you.
Thank you, Stephen, and thank you again, Florence, for that really great and comprehensive and clear presentation. So much appreciated. Thank you for joining us today. We hope to have other exchanges and more interactions with you down the road. So let's all stay in touch with each other. And everyone have a good day, good couple of weeks. Reminder that on October 20th, we have our two fellows presenting, Red Driver and Ohema Boku. And then mark your calendars for November 3rd, November 17th for our November HIV Center rounds. Take care, everyone. Be well.
Yeah.